Dr. Ammara, we are live now.
Yeah. Am I audible? Hello. Can you hear me?
Yes, doctor, we are hearing you.
Yes. Shall I start?
Yes, please.
Yeah. Okay. Good evening, everyone. So today we will be talking about oro-antral communication and its management. So let us start our today's lecture with this proverb: that chapter you are learning today is going to save someone's life tomorrow. So pay attention. So with this quote, we'll pay attention to whatever we are going to learn from this lecture today. So let us make it successful. So let me introduce myself. I am Dr. Ammara Tahmeen. I am MDS in Oral and Maxillofacial Surgery from India. Currently, I am practicing in Dammam, Saudi Arabia. I hold overall 10 years of experience in the field. So let us begin our presentation of oro-antral communication and its management. So in this lecture today we will be discussing about the following contents: the definition and introduction of oro-antral communication, incidence, etiology, clinical presentation, diagnostic criteria, management of oro-antral communication, sequelae of oro-antral communication. So what is oro-antral communication? It is an unnatural communication, which is a pathological communication that forms between the maxillary sinus and the oral cavity. So this is how the oro-antral communication is visualized from the intraoral view. So this is just an overall illustration of the relation of maxillary sinus with the alveolar bone. You can see here, this is the molar teeth, and these are the roots of the maxillary molar, and you can see there is a close relation of the maxillary molar, that is palatal root. Usually palatal root in the maxillary molars are very closest to the floor of the maxillary sinus. So this is how this is the floor of the maxillary sinus forms this alveolar bone of the maxilla forms a floor of the maxillary sinus, and it is lined by a schneiderian membrane or sinus membrane. So let us proceed with the incidence rate. So oral and oroantral communication is one of the most commonly encountered complication in the oral surgery during the extraction of the maxillary molars. Apart from the extractions, it could be due to the failure of the implants, due to trauma, uh, due to the failure of the sinus lift procedures, like direct augmentation procedures for the sinus lift, due to any pathology like apical cyst, periapical cyst, dentigerous cyst, or any other odontogeny pathology such as maxillary sinus infections, osteoarterial of the maxillary jaw, and such pathologies also are the one of the etiological factors for the formation of oroantral communications. So let us see what is the incidence rate of the oroantral communication according to its relation to the maxillary teeth. So bone lamella, the least amount of the bone lamella which is present between the maxillary posterior teeth and the maxillary sinus is approximately about zero point 0.5 mm. So first premolars has the 5.3 incidence rate for the in oroantral communication while the extraction of the teeth, and the 27.2% incidence is seen in the first molars, and 30% seen in the third molars, and most commonly it is encountered during the second molar extraction, that is around 45 percentage, because the palatal root of the second molar is closest to the floor of the sinus. So hence we commonly encounter the oroantral communication cases during the second molar extraction, followed by third molars, and then first molars, and least number of cases are seen related to the extraction of first premolar, that is about 5.3%. So let us move on to the etiology and causative factors for the oroantral communication. So this is a etiological tree. Here we can see there are again oroantral communication upon divided is classified into three types according to its duration. So when is it called oroantral communication? Immediately soon after the extraction of the posterior teeth, if there is a communication between the sinus and the oral cavity, it is termed as oroantral communication. So oroantral communication, as you can see, it is seen after the extraction of posterior teeth, or if there is an infection in the antrum like sinusitis, or due to other sinus involvement, pathology involvement, and surgical removal of cysts and tumors in posterior maxilla, and direct trauma to the maxillary sinus, and periodontal infections. So as soon as you see the communication between the sinus and the oral cavity, it is termed as oroantral communication. So next move on to the oroantral fistula. So when is it called oroantral fistula? Any oroantral communication, if it is not treated within 24 to 48 hours, then it starts to mucosalize. The epithelialization of the this oroantral pathway takes place, and it forms a fistulous tract which becomes permanent opening between the oral cavity and the maxillary sinus. So what are the causes of oroantral fistula? that is infections in antrum and dentular infections again, Paget's disease, destruction of a bone, portion of the sinus by cystotumor, iatrogenic error such as if we encounter oroantral communication during the extraction of the posterior teeth, and if we do not do immediate closure, or we do not take measures to close the communication immediately, it leads to the formation of oroantral fistula. So that is why it could be that is why it's termed as iatrogenic cause, and then followed by again following failure in primary healing of oroantral. In some cases, if you have treated oroantral communication but the treatment fails, then again it leads to the oroantral fistula. So when is it called chronic oroantral fistula? So once it crosses the more than 7 to 10 days of the formation of the oroantral fistula, the patient start developing other symptoms, which we'll be talking about in the next slide. So then it is when once an oroantral fistula establishes and it remains as it is for more than 10 days, then it is termed as chronic oroantral fistula. So along with the chronic oroantral fistula, one of the pathognomonic signs is that it develops chronic maxillary sinusitis, and it leads to the other complications such as other odontogenic infections related to the maxillary sinus. So what is the clinical presentation when there is an oroantral communication? So usually now, as I assume here, most of the people who are attending this lecture are from dentistry, and most of them are general practitioners, as I assume. And if you are into oral surgery and all, so you will be talking about we'll be talking about the vast procedure involved in the management of the orodental communication. But I will be talking most of the part related to the extraction of teeth, because it is most important during the extraction of the teeth. So our topic will be in and around the management of oral communication due to the extraction of teeth. So as soon as you extract the teeth, if you see if you suspect that there is an oroantral communication, usually that's why it is mandatory before any extraction, especially in maxillary posterior region. It's better to go for an orthopantogrammogram or panorama or OPG, whatever we call it. It is better to take an intraoral radiograph or orthopantomograph to see the relation of that tooth to be extracted with the maxillary sinus, especially premolars and molars of the maxillary region. So if by that we can predict whether it's going to be a just simple extraction, or there is a very close relation of the roots of the maxillary teeth with the sinus. Then we can decide and wait we can make a plan B and be ready if in case if you think that there is a communication soon after the uh, extraction, then you can immediately plan the treatment to treat the oral commission. So usually, so there are some clinical tests done on the chair side. These are called Valsalva test or cheek blowing test. So I will explain them in detail in the next slide. So soon after the extraction, if you there is a communication between the sinus and the oral cavity, there will be immediately the patient themselves, they start complaining that they feel some air is passing through their oral cavity into the nose, or they feel some fluid in their sinus, like that. So immediately there then and there itself we can make out that there is a communication. So that is how there is one of the identification procedure. The other thing is that if you suspect there is a maxillary oroantral communication, there are other tests are there, I will explain it later. So when there is an oroantral communication, if it is not closed, If it is less than 2 usually the sinus of the communication, the width of the communication, if it's less than 2 usually it gets unnoticed. The both the doctor, both the surgeon and the patient don't realize that there is a communication. Usually these get healed by the clot formation which takes place during the socket healing phase. So in case if it's more than 2 usually they need surgical intervention to close the communication. So in case if there is a oral communication which is larger in size, more than 2 then the patient can feel air and fluids passing into the nose and the mouth. They will feel foul odor and taste, and there will be unilateral nasal discharge, and the fluids can move in and out of the oral cavity through the nose. And the patient will feel pressure over the affected side, maxillary sinus. There will be pain, discomfort in the cheek region on the same side. And other symptoms, if there is secondary infection which takes place due to the inflammation of the sinus membrane, due to the exchange of the fluids from the oral cavity into the maxillary sinus, the patient will have severe pain. If the blood from the oral cavity has gone into the maxillary sinus, then patient will start bleeding. That nasal bleeding is called epistaxis. And because of the uh, communication of this, there will be nasal resonance. The patient whenever the patient speaks, he will feel his voice echoes. And there will be unilateral nasal obstruction due to the accumulation of the fluids and the blood clot and inflammation of the sinus membrane. So if these signs are noted in the patient, then that is acute oroantral communication. This is seen within 1 or 2 days of the oral communication. If you are seeing this after 48 hours and there is already the epithelialization of the sinus opening, then it is called as oral fistula. Once it crosses 7 to 10 days, more than a week, then it is chronic oral fistula. So if you don't see any of these signs, uh, but with other symptoms are present, like very mild pain, and then the patient has entered into the chronic oroantral fistula phase. So because of the chronic this will be, there will be low grade inflammation. Because of that, patient will not feel any pain, or there will be very mild pain which patient can tolerate. So there will be what happening, because of low grade inflammation, slow inflammation, your sinus membrane will start get thickening. Then thickening of the sinus membrane leads to the development of antral polyps, which are seen as bluish red lumps. When the patient reports after 10 days after the formation of communication, if there is formation of polyp, you can see in the intraoral cavity there will be bluish reddish mass protruding through the opening. That means that there is antral polyp formation has taken place. And the patient will be having hoarseness of voice, and because of the fluid post nasal drip, the patient has the accumulation of fluids which is going into the nasal cavity, and post nasally it is trickling down into your throat. That my patient will have throat irritation. Because of that, he will have cough while he is lying down. All the fluids trickle down into his throat, so he will develop this cough at the night time. And because of the air pressure changes and due to the inflammation, there will be patient will be complaining of earache as well. So this if you are seeing these signs, then it is the patient has entered into the chronic oroantral fistula stages. So during intraoral examination, if you are seeing these polyps through the communication, then you should go for the radiograph such as occipitomental radiograph, panoramic radiograph, CT or CBCT. And if there is discontinuity of the bony floor of the maxillary sinus, then you have to, then there will be increased irregular opacity in the inner aspect of the walls of the mucosal thickening will be seen in the maxillary sinus. And radiolucent shadows also will be there in the center of the maxillary sinus due to the shrinkage of the mucosal lining of the sinus. And also there will in some cases there will be complete opacity of the maxillary sinus on the affected sides, um, due to the collection of the fluid in the sinus. So in this case, that is termed as acute fistula. If you are seeing the clear sinus with thickening of the mucosal lining, then that means it is a chronic fistula. If you're seeing acute fistula, you will see thickening of the sinus membrane, as well as uh, uh, the opacity covering whole of the sinus region. That means it is in acute stage due to the presence of inflammatory fluid. So when you are seeing a visible fistula on inspection of the of the oral cavity, if there is a large fistula, again you have to repeat the same investigations, radiographic investigation, that is CT, CBCT, or panorama. Right now the most commonly used radiographic procedure is panorama, but gold standard for proper identification of the extent of the sinus defect is CT or CBCT. If you don't see any fistula then, or if it's very small fistula, then periapical and panoramic radiographs are very useful, because periapical radiographs they provide with the very clear and sharp and well defined images. So it is very easy to identify these small fistulas or communications on the periapical radiograph. So if you see disruption of the border of sinus, then these cheek blowing test and Valsalva test are carried out to rule out the presence of oroantral communication. During Valsalva test, if you find fine hissing noise, bubbling of the blood into the oral cavity, that means there is an oroantral communication. And during cheek blowing test, if there is a leakage of air through the maxillary sinus and nose, then there is then that confirms the presence of oroantral communication and fistula. So coming to the diagnostic tests which are carried out for the diagnosis of the oroantral communication. So as we were talking about during the clinical examination, this is called Valsalva test. In this test, usually when there are like if you are suspecting there is a presence of oroantral communication soon after the extraction, but you are not able to identify whether it's there, and just for confirmation, the patient is instructed to try to exhale through a blocked nasal airway. If, as you can see in this picture, the patient pinches the nose, and the patient is asked to exhale from the mouth. If the patient once the patient exhales, you will see you should examine the oral cavity in the area of the extraction socket. You will see the air bubble forming in the blood. So this confirms that there is a presence of oroantral communication. In some very small fistulas which are communication which are less than 2 mm, usually this test comes out as negative, but negative Valsalva test does not rule out the presence of oroantral communication. So always detection of this small perforation is not possible. However, if you suspect still that there is a communication, then there are conservative methods to avoid the further complications. So next test is another test which we do chair side, that is cheek blowing test. The patient is asked to blow air into the cheeks against a closed mouth. The patient is asked to close his lips tightly and blow the air. As soon as he blows the air, the if there is a communication, the air leaks into the maxillary sinus through the communication. But this test is considered risky due to the spread of microorganisms from the oral cavity into the maxillary sinus. Due to the transport of the oral cavity fluids through the saliva and all, it might enter due to the blowing of the cheeks with the air. It is possible that your saliva enters into the maxillary sinus through the communication, if at all, if there is communication present. So there's another method, usually which is not recommended, that is the exploration of the perforation with probing. Usually if there is any communication present, it is best to go for the radiographic uh, investigation. Periapical radiograph on chair side is the best method to identify the small or antral communication. So if you try to attempt and check with probing, it might result in the enlargement of the fistula if it's very small, and it may also lead to secondary infection due to the transportation of microbes from the oral cavity. And if at all, if there is just disruption of the bony floor of the maxillary sinus but sinus membrane is intact, you might end up uh, uh, you might end up penetrating the membrane, which leads to the tearing of the membrane, and it leads to the complete establishment of the oroantral communication. So hence it is wise to avoid the exploration of the perforation, or if at all, if you feel there is a communication with probing using straight probes or exploratory probes. So radiological investigations, as we just talked about, this is one of the illustration from the oroantral communication case. As you can see, this is a periapical radiograph in for the second premolar or first molar. From the extraction of the first molar, as you can see, there is a discontinuity in the floor of there is discontinuity in the floor of the maxillary sinus. This is maxillary sinus, and you can see there is no bone here. So this is a proper established oroantral communication. So periapical radiographs, they are preferred because of the sharp and clear quality of images, detailed images, and you can assess the presence of any root fragments in or the foreign bodies, or due to the failure of the implant, if the implant has uh, uh, slipped into the maxillary sinus, so you can get a brief idea of about what's happening exactly. So for immediate identification on the chair side, periapical radiographs are very useful. But so next is the orthopantomogram, as we also call it as OPG, or panoramic view of the oral cavity. So again, it is a 2D view of the defect we can get. And in this picture, as you are seeing, they have placed a gatta parcha to identify the pathway of the this oroantral communication. So as you can see, it is from the oral cavity, it's going into the maxillary sinus. So in this orthopantomogram, you can just know extent of the defect. You can just identify the thickness of the membrane, or fluid levels, or opacity of the sinus can be identified, but it is not clear due to the overlapping of the all skeletal structures in the orthopantomogram. So this is one of the disadvantages of the orthopantomogram. If you want to identify the extent of your sinus defect, the oroantral communication defect. And here, this is one of the uh, drawback of the panorama, that it just provide a 2D view, and there is overlapping of the skeletal structures. So hence it is just for diagnosis. If you want to plan proper treatment for that, then the gold standard of choice of radiograph is either CT scan, or computer tomography, or CBCT, that is cone beam computer tomography. Nowadays CBCT, for every such cases, CBCT is the choice of method for the radiographic investigation. So see, this is one of the sections from the cone beam computed tomography, that is CBCT, for the oroantral communication. I have just put one image I forgot to put the other images. So as we all are aware that CBCT gives us a three-dimensional view of our uh, dentoalveolar apparatus or skull or facial bone structure. So we can see the three-dimensional view of the defect, and we can assess the extent and size and the dimension of the defect, thickness of the sinus membrane, and also we can identify the exact location of the displaced fragments of the roots or foreign bodies or any other sinus pathologies. So this is one of the view of the CT scan. As you can see in this CT scan, you can see enhanced opacity here in this left maxillary sinus region, and you can see the communication of the oral cavity with the maxillary sinus. There is a disruption of the bony floor of the maxillary sinus. As you can see, there is complete opacity, and there is a communication. So this is acute oroantral communication. How can we say it is acute? And because there is soon after the communication there is accumulation of blood into the sinus, which and there is no epithelialization has taken place still. So this you can see the free bone margins here. That means is a fresh oroantral communication with the accumulation of blood and fluids into the maxillary sinus. So the opacity which you are seeing is the fluid levels in the maxillary. Again, you can see in the next image, this is again the maxillary sinus, and this is the disruption of the floor of the maxillary sinus. So there is a communication between the oral cavity and the maxillary sinus. As So as you can see here, from here, this image to this image, you can differentiate. There is a clear radiolucency noted. Okay, and here you can see enhanced radio opacity. That is the thickening. That implies there is a thickening of the sinus membrane. And also you can see this sinus membrane thickness is continuing here. So you can see that this thickening it is continuing here. So as you can see, there are no free bony margins. Can you compare here with these two images? There are free bony margins here. That means it's a fresh oroantral communication. And this one, maybe it's more than 1 week old oroantral communication. So it has led to the epithelialization of the oroantral communication. Once the epithelialization of oroantral communication takes place, that means it is an oroantral fistula. Now this has organized tract, fistulous tract has formed. So that's why there is a clear pathway. Now there is exchange of fluids, everything here. So what happens, all the fluids get drained, but due to some amount of fluid coming in and out of the oral cavity into the sinus, there will be low grade inflammation which causes the thickening of the sinus membrane, and in later stages it might lead to the formation of polyp. So this is how you can differentiate. This is acute and this is chronic. In chronic, you will see the central radiolucency followed by thickening of the sinus membrane with the epithelialization of the tract. Whereas you can see there is no epithelialization, free bony margin. So that means this is chronic oroantral fistula. So coming to the management of oroantral communication, there are various treatment modalities have been mentioned in the literature. There are plethora of technical procedures for the management of oroantral communication or fistula. So I will be highlighting more about the most commonly carried out procedures, and usually which has shown most successful rate. So I'll be talking more about these procedures. So let us move on to the management of the oroantral communication and the fistula. So there are two principles of management of oroantral communication. Coming to the first principle, when you there is an or when you encounter an oroantral communication, especially which has maxillary sinus pathology, such as the patient already, when you are before the you proceeding with the extraction, of the maxillary teeth in during your medical history recording. If patient had complained about his history of maxillary sinusitis, then before proceeding with the closure of the oroantral communication by any surgical technique, you should ensure that your sinus must be free from any type of infection with adequate nasal drainage. So the very first principle of management of oral communication is that before you close your oral communication, you should make sure that your sinus is free of any inflammation or infection. Then comes the second principle, that when once you clear the sinus inflammation or infection, then you proceed to close the oroantral communication. So closure, once the closure is done, you should ensure that your closure of the flap which you used for the closure of the oroantral communication must be tension free, and it should consist of broad based, and it should be well vascularized soft tissue flap over the intact bone. So this is the main principle, that your closure of the flap should be tension free, and it should consist of broad base so that it includes more of the blood supply. So it should be well vascularized so that it should not undergo any necrosis which may lead to the failure of the surgical management of the oroantral, which might lead to other sequelae such as oroantral fistula or other maxillary sinus pathologies. So next, we will be talking about talking more about the uh, management methods which are carried out for the oroantral communication. So, successful closure of the oroantral fistula should be preceded by the complete elimination of any sinus pathology, fistulous tract, sinus infection, degenerated mucosa, and diseased bone. So, before your as this is the first principle. So you should always if you have eliminated the sinus pathology, if you follow the first principle properly, then automatically your second principle of the management will be successful. So, how do you decide the treatment plan for the oroantral communication? So, again, it depends upon the duration of canal perforation. As we have talked about the oroantral communication, when it is recent, as soon as you have done extraction, or as soon as you have any because of any traumatic process, uh, causes, if you see oroantral communication immediately, then if it's less than 2 millimeter, or if it's more than 5 millimeter, or it is between 2 to 5 millimeter, again the treatment plan changes according to the size of the defect. So if it's recent, it's oroantral communication. If it has lasted longer than 48 hours, like if you have done extraction and you did not find any such signs of oroantral communication, and neither you have found nor patient has complained any such of symptoms on the chair, and imagine if the patient has left the clinic and he reports back after 48 hours, that may once when you examine intraorally, you can see there will be epithelialization and there will be exchange of the fluids from the oral cavity into the sinus. That means that is oroantral fistula. If you are seeing this defect after 48 hours, it is called oroantral fistula. So again, if it has crossed more than 10 days or 14 days, then it's called chronic oroantral fistula, that is long standing perforation. So again, the treatment plan differs according to the time, duration, and the size of the defect, and if any other pathologies of the maxillary sinus are present, there are presence or absence of the maxillary sinus pathology like sinusitis also changes your treatment plan. So you have to go with tailored approach for each and every case differently. So if you see oroantral fistula, whether it's chronic or acute, the you have to first clear the sinus pathology, as I told you that we have to make sure that your sinuses are clear. Then you have to go for the excision of the fistulous tract. That epithelial lining of the fistula should be incised clearly around the opening, the epithelial lining which is surrounding the this communication opening. You have to excise completely the epithelial lining of the fistula. Then you have to curate any infected bone or bone sharp bony margins, whatever it is. You have to make sure that the uh, this communication again it's clear of the epithelial lining and any regular bony margins. After that, you have to do the drainage and aeration of the affected masses. That means you have to, if there is inflammation or a presence of infection or any abscess, then you have to irrigate the sinus, maxillary sinus thoroughly from the uh, oroantral communication from the intraoral cavity. Then again, uh, here one more thing is that if the patient has large polyps, antral polyps present into the maxilla sinus as seen in your CBCT or CT radiograph, and you also you can see them in clinically. If there is a large defect, you can remove all the polyps from the intraoral approach itself. If you see there is a small fistula but there are large polyps, it's better to refer the case, or not just you should work along with the ear, nose, and throat surgeon, ENT surgeon, for the functional endoscopic sinus surgery. In functional endoscopic sinus surgery, what ENT does is he enters the sinus through the nasal cavity and they do nasal antrostomy. By endoscopic procedure, they remove all the antral polyps and other sinus so this avoids the enlargement of the fistula, and so hence it prevents the unnecessary enlargement of the fistula, which leads to the again extensive surgical procedure. To avoid this, if you see there are large antral polyps, and which can only be better dealt by endoscopic sinus procedures, then you can work along with the ENT surgeon. So once the ENT surgeon clears the maxillary sinus pathologies, you can proceed with the intraoral closure of the defect. So that's how we deal with the oroantral fistula cases. So let us get into some more details with the different types of treatment modalities, explain into details. So, how do we start the management of the oroantral communications? So, perioperative management or preoperative management, when you see there is maxillary sinus which has inflammation or any sinus infection, if then it should be thoroughly irrigated. As you can see in this procedure, they have placed a drain here. Then, with normal saline, through this drain, the surgeon is pushing the saline into this uh, op- the surgeon is pushing the saline into this opening, and it is going into the sinus, so it is flushing the sinus and coming through the nose. That is middle meatus of the nose. It communicates with the maxillary sinus. So through this meatus of the nose and through the nostrils, your drainage is taking place. That's how the irrigation is done. First the plain saline with normal saline, the irrigation is done. Then 1:1 dilution of the normal saline with betadine solution, that is iodine containing solution. uh, you are going to uh, first you have to just go on uh, pushing the normal saline without any other solution, unless and until you see the clear fluid coming after the nose. So once you see the fluid which is coming out after the draining the sinus, if it's clear, that means you have cleared all the inflammation from the sinus. Then you have to disinfect with the dilution with 1:1 betadine solution to eradicate any microbes present in the sinus to avoid the infection. So this is the first step in the management of the oral and communication. So once you have cleared the sinus pathology, Then we are moving on to the surgical closure of the oroantral communication defect. So there are many techniques have been mentioned in the literature. There are plethora of techniques have been mentioned in the literature, such as most commonly we use are the local flaps, followed by distant flaps, bone grafts, platelet concentrates, and implants. So let us see one by one what are these and how do we carry out these procedures. So again, how do you decide these surgical procedure? Again, it is based on the size of the perforation. As I said, if it's less than 2 mm of the oroantral communication, usually it gets healed by itself by the good clot formation. It's just that you should give patient post-operative instruction that they should not sneeze with the closed mouth or nose. They should avoid uh, touching the clot with the tongue or the fingers, or using of the negative suction such as straws, and such simple measures will help the patient to heal without any intervention required. If there is more than 2 mm of the defect, then we need to go for the surgical closure of the defect. So the defect which are more than 2 mm but less than 5 mm, then if the again it depends upon the position location of the defect. Is it present palatally, or laterally, or buccally, or it is through the alveolar bone, that is through the socket, roof of the socket. So if you see it is in the lateral position or mid alveolar position, then if there is sufficient vestibular depth, then we use buccal flaps, buccal advancement flaps, pedicle subepithelial connective tissue flaps. Again, if there is a large bone defect, then we use so again, next is if you are seeing oral communication in the region of premolars, and if you see sufficient vestibular depth is there, then you can go for buccal flap, buccal advancement flap, pedicle flap, same flaps. And if you suspect there is a big bone defect also, then you need to reconstruct the alveolar region with using bone graft, free mucus grafts, and other grafts. Then coming to the edentulous cases, for most edentulous cases, there is one flap which is commonly used. It's called Moxer flap. So I'll be getting into detail of each of these flaps in the next coming slides. This is just a brief outline of what we are going into next in the lecture. So again, if there is less than 5 mm but there is no soft tissue around the defect, enough soft tissue or bone around the defect, and you cannot take the defects, close the defects from the local flaps, then they usually we have to harvest retromolar bone, usually from the tuberosity area, or a tuberosity area if there is enough tuberosity bone, or we can go for the bone from the retromandibular retromolar bone from the mandible. So there are other gels also which have been used that is called prolamin gel. And then also they have used acrylic sprint and guided tissue regeneration. They place the collagen membrane in the defect which separates the sinus membrane from the alveolar socket, and then they place the bone graft, or they can also use platelet concentrates such as platelet rich fibrin and fibrin gel. And there are very many options. I'll be explaining you in detail in the next slides. So these are the less than 5 mm. So if you are going, if you have defect of less than 5 mm, then you are going to close the defects using local flaps. Okay, then next, size of perforation. If it's more than 5 mm and there is a location of communication is present in the third molar region, then usually most commonly used flap is palatal rotation advancement flap or buccal flap with displacement of buccal fat pad. and palatal pedicle flap, and other epithelial island connective tissue graft. If you see oroanterior communication more posteriorly, that is behind the third molar, and if you see there is sufficient vestibular depth is present, you can use again buccal fat pad flap or anteriorly based palatal flap. In premolar vision, again, if there is sufficient vestibular depth, you will be going with the same procedure. If you don't see any vestibular depth, that means your vestibule is very much flat, then you go for palatal flap. So what happens if you use when there is sufficient there is no sufficient vestibular depth, if you pull the buccal flap towards the defect, it leads to the further obliteration of the vestibule, which may interfere with the seating of the complete denture in the edentulous patients. As of there is no much problem in the dentate patients, but still it can be avoided with other techniques such as palatal flaps. So if you see the sorry if the size of perforation, if it's more than 5 mm, and if there is presence of sinus pathology, again, as I said, you endoscopic procedure to remove the sinus pathology by ENT surgeon, followed by this local flaps. There are other types of flaps, distant flaps, autogenous bone grafts, allogenous bone grafts, platelet rich fibrin, plasmin gel, guided tissue regeneration, and many such procedures. So I will be speaking about them in the next slides. So when there is a defect, as I said you, which is less than 2 mm, so usually what you do is you have to pack the socket with the oxidized cellulose in the socket. As you can see, uh, there was just less than 2 mm of the communication. So this brown thing, what you are seeing is the oxidized cellulose, which is packed into the sinus. Then it is held with the figure of eight sutures using polyglaxon sutures. This after once this is secured with the sutures. As you can see in the post-operative healing phase, the already this defect has closed, and the socket is already into the healing phase, and it has completely seized with the new mucosa formation. So this is the management of the defects which are less than 2 mm. So when you have the defect more than 2 mm to 5 mm, or if it's more than 5 mm but there is no obliteration of the vestibule, this is called buccal advancement flap. It is also famously known as rear man flap. So this is the most commonly carried out procedure for the closure of the oroanterior communication. As you can see here, this is the defect. Once the defect is identified, the two releasing incisions are given at the margins of the defect. As you can see, mesially one as you can see, there is a mesial one vertical releasing incision is placed, and distally one vertical releasing incision is placed, and you try to acquire a wide base so that to include more vascularity as possible. So once you have release the flap, you have to do mucoperiosteal dissection so as to uh, 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 decrease the tension of the flap. So when you bring this flap to close with the palatal margins of the defect, it should close without tension. So usually what happens if there is very less depth of the vestibule, and if you opt for this buccal advancement flap, what happens when you pull the flap towards palatal area, your vestibule becomes very shallow. So usually if you the person is going for the implant, there is no problem. So it's like that. So if there usually if this is problematic when the patient is completely edentulous. If you are using a buccal advancement flap, if your vestibule is obliterated, there will be problem with the interference with the retention of the denture. Hence it is not indicated in the edentulous patients. So once the tension free flap is obtained, that's how it is closed with the palatal margins. So this is most commonly carried out procedure, that is buccal advancement flap, also known as Rehrmann's flap. Okay, the next one is the buccal fat pad flap, or Bichet's fat pad flap. So uh, after buccal advancement flap, this is the most commonly carried out procedure for the closure of oroantal communication nowadays. So in buccal fat pad flap, what you are doing is, if the defect is more than 5 mm, usually if it is more than 5 mm defect, you are going to give first you are going to release give vertical releasing incision, as you have given in the buccal fat flat buccal advancement flap. Just like that, exactly, you are going to dissect and from the at the mucoperiosteum level, and take the make the flap free of tension. Then what you are going to do is, behind the zygomatic process, just below the zygomatic arch, you have to feel extraorally at the zygomatic arch, you have to press there, and from intraorally through the this buccal flap, you have to give a vertical release and incision into the mucoperiosteum, and by blunt dissection you can visualize the buccal fat pad. It is coming out of the uh, fascia. So once you identify this buccal fat pad, you have to use blunt dissecting scissors or mosquito forceps to dissect and pull the buccal fat pad out. As you can see, the protrusion of the buccal fat pad, as you go on dissecting, it comes out protruding through this opening. Once you have dissected the buccal fat pad, you have to push it into the defect. As you push it into the defect, you have to secure it with the sutures. Once you have secured it with the sutures, the buccal flap, as you have uh, uh, advanced it in the buccal advancement flap, just like that, it is just advanced and towards the but here there is a difference, that this flap, it closes just buccally. So your buccal fat pad, it is left exposed into the oral cavity. So this is how it avoids the uh, obliteration of the vestibule, and it just closes your defect buccally. So your this buccal fat pad is left to heal uncovered. So this is left raw. Usually within 10 days the mucosalization of the buccal fat pad take place. So you can see, once the buccal fat pad heals, there will be complete mucosa formation. So one of the disadvantages of the buccal fat pad in patient who are diabetic or immunocompromised, a patient who are poor in oral hygiene and all, they might infect this flap, which might get infected or necrosed. So this is one of the disadvantages, but otherwise it has given very beautiful results clinically, and it is advocated by many surgeons worldwide nowadays. So it is commonly carried out in procedure for the oroantal communication, usually in third molar regions, or third region posterior to third molars. So as you can see clinical picture, this is how the buccal fat pad looks clinically, and after the healing phase, this is how it is. So it goes on shrinking during the healing phase. Once it has shrunken, then the mucosa, it gets the mucosa overgrows the buccal fat pad by like creeping substitution. It substitutes the buccal fat pad, and epithelialization overtakes here. So this is how it beautifully closes the defect. So coming on to the next flap, this is the most chosen flap method for edentulous patients. So this is called Moxer flap. Again, this is a buccal advancement flap of sliding variety. So usually what is done in this particular flap is, Usually this is carried out in edentulous patients to avoid the obliteration of vestibule. But many of the clinicians, they reported that this particular flap, though it is sliding into the cavity without causing any vestibular bleeding, but still postoperatively there will be some vestibular depth decrease. So let us come to how it is carried out. As we saw in normal buccal advancement flap, we give vertical releasing incision at the margins of the defect. But in Moxer flap, the vertical releasing incisions are given to in the mesial or proximal region of to the teeth present. Just example, in this picture, as you can see, there is a defect here. Instead of giving vertical releasing incision here, the vertical releasing incision is given proximal to this teeth present here, adjacent teeth present here. So that's how vertical releasing incision is given and periosteal dissection is carried out. So mucoperiosis, after mucoperiosis, the flap is loosened, and what happens? This flap end, which belongs to here, from this, it is slided over to the defect, and that's how they close this defect. So what happens when it translates here? So there will be no obliteration of the vestibule, but still there will be some will be reduction in the depth of the vestibule, but it is not as much as you see in the buccal advancement flap. So this is why the most advocated procedure in the cases of oral communication in edentulous patients. So if you do this procedure in dentate patients, what happens is, because your attached gingiva from these teeth is lost, the mucosa which takes place, it later it leads to the gingival recession easily due to the absence of the this attached gingiva. So this leads to the periodontal issues with the teeth already present there. So this is why it is better to be avoided in the dentate patients. So, coming to the next flap, it is rotational palatal flap. After the Rearman flap, this is the most commonly used technique for the closure of the oroantral deflects, and it is most preferable in the premolar region, because in the posterior region, due to the rotation of the flap, it might cause the kinking of the artery or bending of the artery, which may lead to the cessation of the blood flow to the flap, which might cause necrosis of the flap, ultimately leading to the failure of the treatment of the oral communication. As you can see, this flap, it is based on greater palatine artery. So this is a palatal flap, and the palate is mostly it is majority of the palate, it is supplied by the greater palatine artery. So what they do here is they place a incision like this, and they make a flap um, uh, out of the palatal mucosa based on the greater palatine flap. Once the dissection is carried out, this flap is rotated into the defect area. Can you see here? After the flap is reflected, and it is still connected to the mucosa here. So it is pedicle flap. This is called pedicle. So this pedicle, it is rotated here over the defect and sutured. So and this area is left raw to be healed by secondary intention. So the secondarily mucosa formation takes place. So this is one of the clinical pictures of this palatal rotation flap. As you can see, it is harvested from here, and this pedicle is rotated here and sutured. And you can see this raw area, it is left uncovered. Usually in some patients, usually who are diabetic, they usually contract secondary infection, which leads to the infection of the uh, uh, operated side. So some clinicians, they prefer to cover it with stent unless and until the complete healing takes place. So in healthy young patient, usually it heals without any issues, but some clinicians, they prefer to close it with some stent or something, which prevents the exposure of the raw site to the oral contaminant. So this is how the so in some cases, usually if it is anteriorly based flap, it is preferred without here one more procedure, that is anteriorly based flap. What they do here is, at the junction of the incisive artery and the greater palatine artery, the flap is reflected from here, and it is covered over the defect, usually in the premolar region. So this one is usually without any tension, but this flap here, what happens, as it is rotated completely 90-degree, which may lead to the bending of the artery, kinking of the artery, which may disrupt the blood supply. So that is one of the drawback of this flap. So coming to the another uh, type of submucosal flap, basically it is like island flap. It is called modified submucosal connective tissue flap. So basically what happens in this flap is, as you can see the defect here, from 4 from the defect, the palatally, one vertical one incision is given. So another incision is given from the first incision, here 2 to 3 mm, 3 to 4 away from the midline of the palate. So the second incision is placed like this, and in between the two incisions there is one more incision placed. That's how the two flaps are reflected. This dissection is carried out at the level of submucosa. So at submucosal level, this is how the two these ends of the flaps are reflected. Then based on greater palatine artery, the connective tissue, there is then they place deep incision into the connective tissue and reflect this flap. Can you see, this is connective tissue flap. So here technical expertise is required, so as to know the correct plane where you are placing the incision, so that if you when you reflect the flap, there should be a thin connective tissue layer should be left. If you give the deep incision till the bone, then this flap will be you cannot obtain this connective tissue flap. So this is requires very much finesse and technical expertise. So once you reflect these two flaps, then you release the connective tissue based on greater palatine artery. So what they do next here is, from the defect and this thin gingival collar, what you are seeing is tunneling is done. Here they use one periosteo elevator. From here they form a tunnel between the flap and the defect. So this tunneling, through this tunnel, this flap is pushed below the this gingival collar and brought here. Can you see, this flap through the this tunnel, it is brought out here onto the defect. That's how it is sutured over the defect. And then this flap, palatal flap, it is closed, so hence it avoids the secondary it avoids the raw uncovered area, as we have seen in the palatal rotational flap here. So this is how there is no secondary donor site morbidity is avoided. Just yeah, there will be surgical wound, but there will be less chances of infection. So and there will be no bulking of the tissue, as we saw in the palatal rotation flap. As you saw, there was the bulking of the other. So clinically, this is how these two flaps are you seeing, these are the reflected, then this is your connective tissue layer. So again they release the connective tissue, and the flap is released. This is how they do the tunneling with the periosteal elevator. So that's how it is brought through the tunnel onto the defect, and that's how it is sutured. And you can see this in the post-op healing phase, it has beautifully healed, and as you can make out, there is you cannot make out any defect here, just a small scar. That's all. So this is how technique sensitive procedure, but give very beautiful results, as it avoids vestibular obliteration and no secondary raw area. So that's how it clear everything very beautifully. So apart from these flaps, again the buccal flap and the palatal flap, they are used together. Both buccal and palatal flaps both are released and brought onto the defect, and they are closed. There are many types of local flaps, but these are the most common and useful flaps and easy to advocate. And most of these flaps, they have shown very good results and with success results. So usually these are the most commonly carried out procedures in the local flap for the oral communication. So coming to the distant flaps, there are lateral tongue flaps. Usually these are used in the traumatic cases of the oroantral communication, such as zygomatic complex fractures, which has created the defect of oroantral communication, or excision of tumors, failure of sinus augmentation procedures, or a failure of multiple implants in the maxillary posterior, which led to the communication of the oral cavity with the sinus. So for the larger defects, usually the lateral tongue flaps have been used. What they do is, from the dorsal of the tongue, from the lateral dorsal area of the tongue, the flap is taken and it is brought, pedicle flap, it is brought onto the defect and sutured. So it is left for 14 days. After 14 days, this is severed from the pedicle, and this flap again it is sutured back to the tongue. So it is very technique sensitive and discomfort, donor side morbidity, because patient has discomfort till the 14 days. Again, the healing is prolonged after, again the in the second stage, again the this flap is sutured back onto the tongue. So it takes a long time, and it is usually very discomforting for the patient. So usually in the cases where other procedures are not indicated, lateral tongue flaps have been considered, especially in the posterior maxillary region with larger defects. So another flap is temporalis flap. Again, it is usually carried out in the larger maxillary sinus defects, orovantral defects, such as excision of tumor, or excision of tumor, or sinus pathologies, or osteoradionecrosis, osteomyelitis of the maxillary jaw. There is a big bone defect along with the sinus communication. Temporalis flap has been used to cover these defects. Other distant flaps, which are beyond the scope of this lecture, and is like other flaps, free flaps, radial forearm free flap, uh, submental island flap. Such flaps are, many flaps are there. These are free flaps, these are called free flap, that also have been used, but for larger defect. So our this lecture is mostly related to the dentioalveolar causes, so we'll stick to these local flaps more in detail, that's all. So these are the distant flaps which are used. The other one is the auricular cartilage graft. So auricular cartilage from your ear pinna, the posterior. This is the posterior part of your pinna. Here you have the thick cartilage. You can harvest this auricular cartilage. This is auricular cartilage, which is harvested from the posterior surface of your ear pinna. This is it has been reported that it is it has given very successful outcomes for the management of oroantral communication. It is placed between the socket and the sinus membrane, so it forms a barrier between the sinus membrane and your alveolar socket. So because it is non-vascular, so it does not require any blood supply, so it has very few chances of going it has no chances of undergoing necrosis, and it forms a very thin barrier between the sinus membrane and the alveolar bone, so it leads to the healing of the sinus floor, and as well as it leads to the normal formation of the healing of the socket bone. So this has been used as a barrier membrane in many of the clinicians. But again, it is technique sensitive. And it has donor site morbidity. This is the problem that the patient will have to deal with the two wounds. One is extraorally, and the other one is intraorally. So hence we should opt more for local flaps as much as possible, unless and until it is contraindicated. So coming to the bone grafts in the management of oral intercommunication, when there are large defects and or when the patient is in need of the replacement of the tooth in future, that is for implants, so then we have to consider the bone grafts. The most commonly used bone grafts are autografts harvested from your extraction sockets from the adjacent tooth. Intraoral sites like anterior mandible, that is anterior border of ramus, is the one of the most commonly used site for the harvesting of bone graft, autograft. Or distant sites like iliac crest also have been used for repairing the bony defect in maxilla. And so for our if you are, it is related to just extraction site, then then we most commonly used are the allografts. Also we have used with guided tissue regeneration membrane, that is GTR membranes, like collagen membranes. So other one more is press fitting monocortical block grafts. We get blocks of the bone graft. This is allograft. As maybe most of you have seen, like we get the bone graft in the form of granules or powder, and we also get the blocks in different shapes, in rectangular shapes, in square shape, in cylindrical shapes. So these grafts we can directly press into the socket along with the membrane. What they do is they sandwich the um, uh, bone this monocortical block graft between the membranes. So they push one membrane inside to form the barrier between the sinus membrane, and then they press fit this monocortical block graft in the socket, and then they cover the graft with the platelet rich fibrin membrane or collagen membrane, and that's how they close it. And in after the healing has taken place, if the if there is a more much need of the bone, then they go for the sinus lift or sinus augmentation procedure secondarily. So this is how this is one of the management of the orodental communication if the patient is looking for the implant procedure in future. If you directly, if the patient is need to be replaced with the implant in future, if you're directly closing with the just local flap, and then there will be uh, very in the next stage, when the patient planned for implant, there will be no bone, so again it will be secondary operation with more extensive process. So you are just increasing the time of the patient for prolonging the patient treatment. So immediately, if there is need to be need of the teeth to be replaced, it's best to do the bone grafting, followed by with the closure of the sinus. And in near future, if any other sinus lift procedure is along with the placement of implant can be done. So coming to the post-operative management and adjunctive care of the so once the procedure has been carried out, then post-op care is very crucial for the treatment to be successful. So the patient should be explained very carefully how to the follow the instruction, because it requires both from the doctor and the patient to put in the effort for the treatment to be successful in outcome. So the patients should be instructed not to eat hard food items, just eat soft food items and drink fluid from the opposite side to avoid trauma to operated site. So they should avoid strenuous physical activities such as working out in the gym, lifting heavy equipments, bending and carrying some heavy baggage or whatever it is. The patient should avoid this strenuous physical activities. When the patient bend and lift the heavy weights, it puts pressure into your head and neck region. Subsequently it puts pressure into the sinus region, which may increase intrasinus pressure, which may lead to the opening up of the flap. So next is the nose blowing and sneezing with a closed mouth is prohibited for 2 weeks. The patient should be instructed to avoid nose blowing and sneezing, holding while closing the mouth. So they should, when the patient blows the nose or sneezes when his mouth is closed, what happens? It increases the pressure in the mouth again, which may create the suction effect, and it might open up your sutures and pull out your flap from the defect, which may lead to the failure of the treatment. So the 2 weeks are the crucial for the healing of these flaps for the oral intercommunication defects. Then patient should open mouth while coughing or sneezing. So patient should be ensured that he does not close his mouth while he's coughing or sneezing. And the patient should be instructed strictly not to uh, manipulate the operated site or touch with the fingers or roll the tongue over the defect for at least 1 week after the surgery. And the patient should be strictly instructed to carry out the oral hygiene procedures such as rinsing the mouth regularly with warm saline. If the patient cannot have warm saline in hand, he can take lukewarm water with 1 teaspoon of salt. The patient should be instructed to clean the mouth after every meals with warm saline mouth rinses. And the patient should also avoid using straw. And smoking also. So smoking, again, it creates negative pressure in the mouth, as well as it impedes the healing by decreasing the vascularity and promoting the inflammation. The patient who are smokers should be instructed strictly about the outcomes of these habits. And for the and then the next, the patient also should use a steam inhalation such as using menthol or benzoin in the steamer. They should take water. Once the water is hot, when the steam is being created, they should add menthol or benzoin, and every 6 hourly they should take this inhalation of the steam, which moistens the airway, and which what happens, it uh, uh, increases the uh, uh, decreases the viscosity of the fluids in the maxillary sinus, and it moistens the sinus, which leads to the free flow of the sinus secretions and clears the sinus cavity. So this is how the infection due to secondarily due to the procedure during the healing phase is avoided. So it also prevents the crusting of blood when there is uh, when there is steam being taken place. So it provides a moist environment, so it loosens the debris in the sinus and blood if there is some blood from the operative procedure present in the, and it prevents the crusting of the blood and mucus. So that's how the healing is promoted faster. So, along with these instructions, the patient should be put on the antibiotic therapy. The most commonly prescribed medicine is the amoxicillin plus clavulanic acid. That is most commonly we use is the augmentin or amoxiclav. The patient is prescribed this medicine 1 gram twice daily by orally, or if the patient is unable to take by oral, then they can go for IV uh, infusions of the amoxicillin plus clavulanic acid. Or if the patient is allergic to the penicillins, then the antibiotic of choice is clindamycin. That's 300 milligram 3 times daily for at least 5 days. But what I prefer is mostly we should give this medicines for around 1 week at least. So along with this antibiotic therapy, like you can give also analgesics for the post-operative pain management, such as Brufen, that is ibuprofen 400 milligram thrice daily, or diclofenac 75 milligram injections, or oral analgesics, or paracetamol 1000 milligram thrice daily for 1 week for the management of post-operative pain and inflammation. So along with this, to avoid the congestion of the nose due to the mucus secretions of the sinus, for the free flowing of the fluids from the sinus, decongestant nasal drops such as Otrivin, that is xylometazoline 0.05%. The patient, after taking inhalation, steam inhalation, the patient is advised to use these nasal drops or spray to avoid the nasal congestion. So this shrinks the nasal mucosa and keep antral opening clear and patent for the drainage of the okay. So coming to the summary. So, in the absence of any infection of maxillary sinus, defects which are smaller than 2 mm can heal spontaneously following the blood clot formation and secondary healing. And the untreated larger defects can lead to development of acute sinus diseases like sinusitis in 50% of patients within 48 hours and 90% of patients within 2 weeks. So closure of this communication is mandatory to prevent any food or saliva accumulation, which can result into sinus contamination, leading to infection, impaired healing, and chronic sinusitis. According to Wasserman, as he has reported that development of sinusitis in 60% of cases by fourth day after sinus exposure is confirmed, while Aniroth and Martins also reported cases of sinusitis at the rate of 50% by third day after oral-antral communication is encountered. So, to avoid further complications, confirmatory and early diagnosis is mandatory for successful closure and outcome. And management of oral communication to promote closure should be done within 24 to 48 hours. If you are not experienced enough to manage these cases at your clinic, then it is mandatory that you refer to the nearby oral and maxillofacial surgeon, or ask the patient to consult oral and maxillofacial as early as possible, because as the patient crosses the 24 to 48 hours of window, then it enters into the oroantral fistula stage, which leads to the further complications. To avoid further complications, and to provide patient utmost care, it is wise to refer the patient to the oral and maxillofacial as early as possible if it cannot be handled by the general dentist in the clinic. So, in cases with oral-antral communication which are larger with the history of sinus disease, surgical closure is indicated, possibly with ENT intervention, as we have discussed in this lecture. So, we have reached to the end of the lecture. So, I will be concluding with this conclusion that correct diagnosis of oroantral communication and immediate treatment is crucial for the healing of oroantral communication. Suitable treatment technique is the deciding factor for the successful outcome and prevention of subsequent sequelae associated with the worsening of the oroantral communication and oroantral fistula. So these are my references. So this ends our lecture today. So thank you for being the patient listeners. This was my first lecture at the international level and to this wide the public audience. So I hope it has been beneficial for you and your And if have any shortcomings, you can give the feedbacks, and also your good suggestions are welcome. If we in future, in near future, if we have any other lectures, so we'll consider your feedback definitely, and your suggestion also welcome. And if anybody has any questions, we are open to the question as well. So thank you once again, and I also want to thank you, this Dentalist Max organization, Dr. Abubakar and others, for giving me opportunity to present on this platform, and believing in me to speak out to such a wide audience. Thank you once again. Have a good day.
Thanks a lot, Doctor, for this great lecture.
Welcome, doctor. It's my pleasure.